Welcome to the Funnel Effect.
Hello.
Today we are taking a deep dive into a vascular disease that's, well, it's rare, often missed early on, and potentially catastrophic if it's left unchecked.
That's right. We're talking about Takayasu Arteritis.
And we're aiming to synthesize the current landscape of understanding, really digging into everything from the genetic risk factors right through to the sophisticated management strategies available now.
And our source material for this pretty extensive exploration is a comprehensive JCC-focused seminar. It's titled Takayasu Arteritis, published in 2023.
Good.
Authored by George Joseph, Ruchika Gul, VGS Thompson, Elizabeth Joseph, and Debashish Danda. It really lays out the clinical roadmap for understanding this condition.
So the mission for us today is clear. Chart the complexities of Takayasu Arteritis, or TEKE as it's often called. You need to define what it is, understand the bizarre way it can progress in stages, and uncover how specialized centers are finally starting to get a handle on this crippling chronic condition.
And we absolutely have to start with the gravity of the disease. TAC is what we call an idiopathic large vessel vasculitis.
Idiopathic meaning we don't know the exact cause.
Exactly. Unknown cause. Think of it as chronic, unexplained inflammation that targets the body's absolute biggest highways, the aorta and its main branches.
Right.
And the terrifying reality is that it overwhelmingly targets young women, typically between 20 and 30 years old.
That young, wow.
Yeah. And the very early stage, we call it the propulseless stage, is often missed entirely, just completely overlooked.
Why is that?
Because the symptoms are just so vague, non-specific. We'll get into that.
Okay, so we're tracking a kind of insidious, slow attacker here.
Yeah.
If this disease is left to progress unchecked, what happens?
It causes dramatic obstructive lesions. The arteries basically start closing up, and that leads to the classic pulseless presentation.
Which sounds quite literal.
It can be.
Yeah.
And the results are severe outcomes like stroke, heart failure, or even aortic rupture, catastrophic events.
So the name of the game here really is specialized lifelong surveillance.
Absolutely, it's critical.
All right, let's unpack this. We should start with the fundamental definition. And you mentioned it briefly, but the history of its discovery sounds quite compelling.
Okay, so to define TAC precisely, the technical term is a chronic idiopathic granulomatous large vessel vasculitis.
Okay, let's break that down. Chronic, long-lasting, idiopathic unknown cause. Large vessel.
That defines the primary targets. The aorta, its main branches, think carotid, subclavian, renal arteries, and significantly the pulmonary arteries too.
Pulmonary arteries as well, that's interesting.
Yes, it's not just the systemic circulation. And granulomatous, what does that tell us about the inflammation itself?
That's the key pathological feature. It indicates a specific, highly organized type of inflammation where immune cells, mostly macrophages, cluster together. They form these structures called granulomas.
Ah, okay. This is a characteristic hallmark of the disease, pathologically speaking. And it's part of why the damage is so extensive and causes so much scarring. It's a deep, destructive reaction within the arterial wall itself.
Not just surface inflammation.
Not at all. It goes deep into the structure.
Now, you mentioned the demographic profile. It seems almost laser-focused on young women. That's consistently emphasized in the source material.
It really is a defining characteristic. Patients typically experience symptom onset between 20 and 30, as I said.
But not always.
No, absolutely not. Onset after 40 is definitely seen, and it actually varies quite widely depending on the region geographically.
Right.
But the female preponderance is striking, though critically, that ratio female to male is extremely heterogeneous across the globe.
That heterogeneity is remarkable. Are we talking differences that would drastically change a clinician's suspicion based purely on where the patient is from?
Precisely. The source material highlights some massive variances. For example, in places like Turkey, the female-to-male ratio can be as high as 12 to 1.
12 to 1.
Yeah, but compare that to populations in China and India, where the ratio narrows significantly, maybe down to around 3 to 1.
Still predominantly female, but much less extreme.
Correct. So while TAC exists worldwide, it is generally considered more prevalent among Asian populations. The global prevalence estimates range quite widely, maybe 3.2 up to 40 cases per million.
So quite rare overall.
Definitely rare. But this geographical difference means a physician's level of suspicion has to be tuned not just to age and sex, but also ethnicity and geography.
It sounds like a rare disease, yeah. But the diversity in how it presents makes it this complex global medical puzzle.
That's a good way to put it.
Now let's turn to the name. Mikito Takayasu. We often think of these eponyms, disease names, as coming from one single brilliant insight.
Well, this story is actually a bit better because it really highlights the collaboration needed in medicine. It wasn't just one person.
Aha.
The year was 1905 in Japan. Mikito Takayasu, who was an ophthalmologist and eye doctor, he presented the initial finding.
So he wasn't even looking at pulses or arteries directly.
No, not the large ones. He was looking through his scope at the retina of a young woman, and he saw these unusual wreath-like anastomoses.
Wreath-like anastomoses. What are those?
Basically, tiny new blood vessels forming in the back of the eye. Why? Because the larger arteries leading to the eye were getting obstructed. There wasn't enough blood flow, so the eye was trying to compensate by growing these little bypass vessels. He was seeing the result of arterial failure way downstream.
So an eye doctor noticed a subtle sign of vascular failure, totally removed from the main site of the disease in the chest or abdomen.
Exactly. But here's where the connection was really cemented. At the very same medical meeting.
No, the same meeting.
Yes. Two other ophthalmologists, Katsutomo Onishi and Tsukichi Kagoshima, presented similar eye findings in their patients. But they added a critical observation. Their patients also had missing radial pulses.
Ah, the pulse connection.
That was the key. It immediately linked the ocular ischemia, the lack of blood flow to the eye, directly to the obstruction of the large arteries in the neck and chest, like the carotids and subclavians.
Got it.
That dual finding the specific eye changes and the pulselessness is what established the fundamental connection that defines Takayasu arteritis. It was a failure of the major arteries detected via the eye.
That historical anecdote, that's a perfect lead-in to the progression of the disease itself. You mentioned the propulseless stage is kind of the clinical Achilles heel.
It absolutely is.
The most dangerous time because it's so easy to just dismiss.
It's the ultimate diagnostic trap. Now, while only about maybe 19% of patients actually experience the full classic triphasic pattern, understanding this typical progression is vital for catching it early.
Okay, so let's detail stage I, the propulseless phase. What are we looking for, or what should we be looking for, and why is it so commonly missed?
Stage I is defined by these really nonspecific constitutional symptoms. We're talking low-grade fever, maybe just feeling generally unwell, profound malaise.
Just feeling run down.
Exactly.
Good.
Significant unexplained weight loss, maybe over 2 kilograms. And just general muscle and joint aches, myalgia, arthralgia.
Sounds like the flu, or any number of things.
Precisely. These symptoms are so generic they mimic almost any viral infection, or maybe a minor autoimmune flare-up. Clinicians often just treat the symptoms.
Right.
The only major systemic clues at this point might be elevated inflammatory markers in the blood, like the ESR erythrocyte sedimentation rate or C-reactive protein, CRP.
But those are non-specific, too.
Highly nonspecific, and because there are no definitive vascular signs, yet no missing pulses, no brutes, the diagnosis often faces an unacceptable delay, sometimes years.
Years. Wow. So the patient is basically trapped in this loop of feeling generally unwell, maybe getting tests for other things.
Exactly.
Until the vascular damage becomes, well, catastrophic. But once it hits stage 2, the pulseless phase, the disease announces itself much more loudly.
It does, unfortunately. Stage 2 is the direct consequence of active, unchecked vascular inflammation that has now caused measurable structural damage and ischemia, that critical lack of blood flow.
Okay.
This is where the classic severe signs appear. Pulses that are weak, diminished, or maybe entirely absent, especially in the arms.
The namesake symptom.
Yes. Also, vascular brute, that's an audible swooshing sound a doctor might hear with the stethoscope over a narrowed artery.
Turbulent flow.
Exactly. Turbulent blood flow. And sometimes localized vascular tenderness. The artery itself might be sore to the touch.
And how does the patient feel this? It must manifest as severe loss of function, right?
Absolutely. The ischemic symptoms can be crippling. You see limb claudication pain, especially in the upper limbs when using them, because the subclavian arteries supplying the arms are often blocked.
So pain when brushing hair, lifting things?
Yes. Also dizziness, fainting spells, angina, chest pain, and critically, severe cerebrovascular events like TIAs, transient ischemic attacks, mini strokes, or even full-blown strokes.
That's terrifying.
It is. And if the renal arteries feeding the kidneys are involved, you can get aggressive, hard-to-control renovascular hypertension, high blood pressure driven by the kidneys. This phase is incredibly dangerous because the damage is active and potentially leading to permanent deficits.
And then there's stage 3, the fibrotic stage. This is the long-term aftermath, even if the systemic stuff, the fever and inflammation, have quieted down.
Right. Stage 3 is often called the burnt out or legacy phase. The active inflammation might be gone, but the permanent vascular damage remains. The artery wall has scarred, thickened, maybe it's dilated into an aneurysm.
So the fire is out, but the building is damaged.
Excellent analogy. This stage presents with chronic complications driven by that structural damage, things like severe heart failure, often due to aortic valve regurgitation because the aorta itself is damaged near the valve, or the potentially fatal risk of an aneurysm rupturing. The systemic inflammation might be gone, but the structural damage dictates the patient's long-term fate and risk.
Okay, so let's step inside the vessel wall for a moment.
Sure.
What is the actual pathological sequence happening that causes this progression, from vague fever to crippling obstruction or dangerous aneurysms?
It's described as a panarteritis. Pan, meaning all layers. So inflammation across all 3 layers of the artery wall, the intimate inner lining, media, muscle layer, and adventitia, outer layer.
All 3 layers are hit.
Yes. And the initial site of attack, interestingly, is often thought to be around the vas viscorum.
The vasa vasorum, those are the blood vessels of the blood vessels, right? The tiny network supplying the artery wall itself?
Exactly. The tiny plumbing system for the artery wall. So the immune system isn't just attacking the main highway. It seems to be attacking the highway's own tiny supply lines first.
Which then causes the whole structure to fail.
That's a great way to think about it. You attack the artery's vital supply line. In the active phase, pathologically, we see infiltration by mononuclear cells, lymphocytes, plasma cells, and crucially, a catastrophic fragmentation of the elastic fibers.
The elastic fibers, those are key for the aorta's function, aren't they?
Absolutely critical. The elastic framework allows the aorta and large arteries to stretch and recoil with each heartbeat. In TAC, that framework is literally being shredded. This is often accompanied by that giant cell granulomatous reaction we mentioned earlier, those clumps of immune cells.
And the end result of all this destruction within the wall.
As the body tries to heal, or maybe just scars over, we see 2 primary outcomes pathologically. 1, reactive fibrosis, just excessive scar tissue combined with intimal proliferation, which is thickening of the inner lining.
Okay.
This leads to stenotic or occlusive lesions. Basically, the vessel scars shut and blocks blood flow. That's one path.
And the other path.
2, if the elastic fibers and smooth muscle cells in the media, the middle layer, are severely destroyed, the wall weakens dramatically. This leads to vascular dilatation and aneurysm formation. The wall balloons out because it's lost its structural integrity.
So blockage or ballooning.
Right. And the source material notes something quite striking. The amount of periadventitial fibrosis scarring around the outside of the artery seen in TAC in the healed phase actually exceeds that seen in almost any other inflammatory disorder of the aorta. It leaves behind uniquely destructive scarring.
That's incredible. Now, returning to that theme of heterogeneity you mentioned, the lesion location isn't uniform globally. That must present a huge clinical challenge. How does it vary?
Absolutely. Geography significantly influences where the damage is typically found. Our source provides some compelling data from Table 4.
Yeah.
It seems white and East Asian patients, particularly those in Japan, tend to have more involvement of the aortic arch branches, the arteries going up to the head and arms, and they often present at an older age.
Older? How much older?
For instance, in Japanese cohorts, something like 43% of patients had disease onset after age 40, which breaks that classic young woman stereotype a bit.
Right. But the focus shifts geographically, you said, south and west.
Dramatically so. Patients from South Asia, like India and also Mexico, tend to present much earlier, fitting that younger profile more often. And they show a much greater prevalence of abdominal aorta involvement.
Down lower in the body.
Yes. For example, in India, almost half, 49% of patients present with what's called type V disease, which affects the entire aorta, thoracic and abdominal, plus its branches. And in Mexico, that figure is even higher, maybe 69%.
Wow, that's a huge difference in pattern.
It is. And furthermore, even the symptoms can differ based on location. Headache, for instance, is reported in maybe 70% of Mexican patients, but only 8% of Japanese patients. A clinician really has to know these epidemiological nuances to have the right index of suspicion based on who is sitting in front of them.
Okay, so we've seen the devastating results of the inflammation and the scarring inside these major arteries. But let's rewind a bit. What actually triggers this attack? Why does the body suddenly decide that its own aorta is an enemy? This takes us into the really complex stuff, the pathogenesis and genetics.
Right. This is where the why comes in, though it's still not fully understood. The current thinking is that large arteries normally enjoy a degree of what's called immune privilege. They're somewhat shielded from the immune system.
How?
Well, the first line of defense seems to be the vascular dendritic cells located near those vessels we talked about. They're supposed to act as immune gatekeepers.
Okay.
But in TAC, the hypothesis is that these gatekeepers are somehow flawed. They might be inherently abnormal, maybe pre-primed for trouble. They seem to have lower expression of certain regulatory receptors that normally keep the peace.
The calm down signals.
Exactly. And at the same time, an overexpression of sensors like toll-like receptors, which makes them hyper-responsive to potential triggers.
So the system is kind of structurally vulnerable, just waiting for a trigger.
Hmm.
What are the presumed triggers then? Are they known?
Still somewhat mysterious, unfortunately. They're often termed putative antigens. There's suspicion around microbial exposures, maybe latent Mycobacterium tuberculosis infection, for example.
TB. Interesting link.
It's been debated for a long time. Or perhaps it's endogenous antigens, things from our own body, like heat shock protein 60, which might somehow mimic something on the vessel wall, triggering cross-reactivity.
Molecular mimicry.
Precisely. So once activated by one of these unknown stimuli, these abnormal dendritic cells mature and start releasing powerful first response pro-inflammatory cytokines, specifically interleukin-12, IL-12, IL-23, and IL-1s. These are key initiators.
And this cytokine release is basically the opening salvo of the whole destructive process.
That's exactly right. It's the signal flare. It calls in the cavalry specifically highly vasculitogenic T helper cells, known as Th1 and Th17 cells, along with CD8 plus T cells and macrophages. These cells infiltrate the arterial adventitia, the outer layer.
And what do they do once they get there?
They unleash chaos.
Huh.
The T cells release cytotoxic proteins, things like perforin and granzymes, which are essentially cellular assassins killing vessel cells.
Wow.
And the macrophages release toxic reactive oxygen species and enzymes called matrix metalloproteinases, which literally chew through the structural components of the artery wall, like collagen and elastin.
So it's a multi-pronged attack from within.
It is. This destructive combination leads directly to the death of vascular smooth muscle cells, the disruption of that crucial elastin framework, and then the subsequent medial thinning and potential aneurysm formation we discussed in the pathology section.
Now, the source material also specifically emphasizes B-cell-mediated autoimmunity. That points towards the involvement of antibodies, right? Specific, measurable antibodies. This is where the molecular findings get really fascinating.
This is one of the really insightful recent discoveries, yes. Researchers have identified specific anti-endothelial cell antibodies, or AECAs, in TAC patients.
Okay, antibodies against the vessel lining cells.
Exactly. And crucially, they've even identified some of the specific targets of these AECAs on the endothelial cell surface. Two important ones are the endothelial protein C receptor, EPCR, and scavenger receptor class B type 1, SRB1.
EPCR and SRB1. What are those receptors supposed to do normally on the vessel lining?
Think of them as the arterial lining's own built-in calm-down switches or brakes. Normally, they act as powerful negative regulators of endothelial activation. They help keep the vessel lining quiet, non-inflammatory, non-thrombotic. They essentially signal to the immune system, stand down, everything is fine here.
Okay, vital peacekeepers. And when these AECAs, these antibodies, attach to and block those specific receptors,
the calming signal is effectively silenced. The negative regulation is gone, the brake is off. This results in a persistent, severe pro-inflammatory phenotype in the endothelial cells. The arterial wall gets stuck in this high alert state.
so the immune system is essentially locking the inflammation switch in the on position by blocking the off switch.
That's a perfect way to describe it. It prevents the vessel from ever achieving true immune peace.
Moving from the mechanism to the predisposition genetics, is there a strong inherited component that makes some populations, like the Asian groups you mentioned, more vulnerable?
There is definitely a complex but quite robust genetic contribution. The single strongest genetic signal found consistently across multiple ethnicities comes from the human leukocyte antigen region, specifically an allele called HLA-B52.
HLA-B52? That points directly to the immune system's recognition patterns.
Exactly. It suggests that certain ways the immune system is genetically programmed to recognize self versus non-self predispose an individual to developing TAC.
But it's almost never just one gene in these complex diseases, is it?
No, rarely. Recent large meta-analyses confirm is what we call a polygenic risk model, multiple genes contributing small amounts of risk. We see synergistic effects from non-HLA genetic loci as well.
Such
For
as?
instance, specific variations in genes like IL-12B, which codes for subunits of those key trigger cytokines IL-12 and IL-23.
The initiators we just talked about.
Right, and also IL-6, which codes for another major pro-inflammatory cytokine, interleukin-6. Variations in these genes have been clearly identified as susceptibility loci.
So the genetic predisposition is directly linked to the specific inflammatory pathways known to drive the disease. That makes sense.
It provides a coherent picture, yes.
Okay, finally, in this section, what about the role of accelerated atherosclerosis? It seems like having chronic inflammation battering your arteries combined with traditional risk factors would be a recipe for disaster.
It is absolutely a major concern. It's like a triple threat that clinicians have to manage aggressively. Accelerated atherosclerosis definitely contributes significantly to cardiovascular adverse events, heart attacks, strokes, and TEAC patients.
How does that triple threat break down?
Well, first, you have the chronic systemic inflammation from TAC itself constantly injuring the vessel walls, promoting plaque buildup. Second, many patients also have traditional cardiovascular risk factors, maybe high cholesterol, smoking, diabetes.
Right.
And third, unfortunately, some long-term treatment side effects, particularly from high-dose or prolonged glucocorticoid steroid use, can actually worsen things like lipid profiles and blood pressure, potentially accelerating the atherosclerotic process even further. It's a vicious cycle.
Okay, so given everything we've discussed, the non-specific early stage, the rarity of the condition, the complex pathology diagnosis is clearly the central challenge here. The initial classification systems must have been quite difficult to apply effectively in a real-world clinic setting.
They were, very much so. Some of the original diagnostic criteria, for example, like the one proposed by Ishikawa initially, had an obligatory age criterion: you had to be under 40.
We already know that's not always true.
Exactly. That proved far too restrictive, immediately excluding patients we now know have TEC, like the later onset groups. And the lack of specific diagnostic markers often meant physicians basically had to wait until advanced lesions, like missing pulses, appeared, which is often too late for optimal outcomes.
So let's talk about the ACR 1990 criteria,
Yeah.
the American College of Rheumatology ones. How did they try to standardize things, and what were their limitations?
Right. The ACR 1990 classification criteria were primarily designed for clinical research, really to make sure different studies were looking at similar patient groups. They used 6 criteria:
Which were?
age at onset, less than 40 years, there's that age limit again, claudication, especially of the limbs, decreased brachial artery pulse in one or both arms, a significant blood pressure difference, more than 10 millimeter Hg between the arms, an audible bruit over the subclavian arteries or aorta, and finally, arteriogram abnormalities consistent with TACO.
Okay, so the main limitation was still that strict age cutoff.
That was a big one, yes. It immediately excluded a significant portion of the actual patient population, particularly those later onset patients common in East Asian and white populations. Plus, it sometimes struggled with patients who might have, say, isolated aortic or pulmonary artery involvement without the classic pulse abnormalities in the arms yet.
Right. So how did the modified Ishikawa criteria from 1995 improve the situation for the clinician trying to make a diagnosis?
This was a really vital advance because it crucially removed that arbitrary age restriction. And it significantly boosted clinical utility, achieving pretty high sensitivity, around 92.5%, and specificity, about 95%.
How did it work? What was the framework?
It introduced a system of major and minor criteria. You needed either 2 major criteria met things like specific lesions identified in key arteries, like the middle or distal subclavian,
Okay.
or you could meet the diagnosis with 1 major criterion plus 2 or more minor criteria, or even just 4 minor criteria.
And what were some minor criteria?
Things like a high ESR, that inflammatory marker, hypertension, characteristic vascular brutes, or even tenderness over a carotid artery or aortic regurgitation found on exam.
So much more flexible.
Much more flexible. This allowed clinicians to diagnose patients earlier, even if they didn't present with that absolute classic pulseless picture right away.
Okay, so beyond the clinical signs and these classification criteria, imaging must be where physicians can really transition from suspicion to certainty. What are the key imaging tools used today?
Oh, imaging is absolutely non-negotiable for diagnosing and managing TAC. Computed tomography angiography, CTA, and magnetic resonance angiography, MRA, are really the workhorses.
CTA and MRA?
Yes. They are used to directly visualize the arteries and reveal the characteristic features: luminal narrowing or stenosis, dilatation or aneurysms, thickening of the vessel wall itself, and sometimes calcification in later stages. CTA, in particular, is often preferred initially because it's rapid and gives excellent spatial resolution of the structural changes.
Is there a specific visual signature on CTA or something that really shouts Takayasu to a radiologist?
Yes, there is actually a distinct and highly characteristic finding, especially on delayed contrast-enhanced images. It's known as the mural double ring sign.
Mural double ring. Okay, intriguing name.
It is, and it's typically seen on axial or cross-sectional CTA images. It's almost like visual proof that the inflammation is indeed starting from the outside layers of the vessel wall, as the pathogenesis suggests.
Can you walk us through what that double ring actually represents pathologically? What are we seeing?
It's quite incredible when you break it down. The double ring consists of two distinct layers within the thickened artery wall. The inner layer appears as a poorly enhancing, darker rim right next to the blood flow channel.
Okay.
That represents the hyperplastic intimal, the thickened inner lining, and probably some scar tissue formation. The vessel lining is thickening inwards, narrowing the lumen.
Right. And the outer ring?
The outer rim is the fascinating part. It's a bright, late-enhancing rim. This brightness represents intense vascularity specifically, visorum near angiogenesis. New, tiny blood vessels are growing profusely within the inflamed media and adventitia.
The artery's lifeline proliferating wildly.
Exactly. It's part of the intense inflammatory response. Seeing this sign is highly suggestive of active inflammation currently happening in the arterial wall, even if the patient's systemic inflammatory markers like ESR or CRP are only mildly elevated or even normal.
That distinction seems critical. The difference between just seeing structural narrowing on MRCTA versus knowing if there's actual current inflammatory activity. How do physicians assess if the disease is metabolically active right now, rather than just looking at old scars?
That's precisely where functional imaging comes in, specifically FDG PET, positron emission tomography combined with CT.
PE scans.
Yes. This uses a radioactive glucose tracer, FDG. Areas of high metabolic activity, like sites of active inflammation where cells are consuming lots of glucose, will light up brightly on the PT scan.
So it shows where the fire is currently burning.
That's the idea. It's incredibly useful for the initial diagnosis confirming active vasculitis and also for guiding the first round of therapy. If the vessel wall lights up significantly, you know you have active disease that requires aggressive immunosuppression.
But you mentioned limitations earlier. What are the downsides for using PT in long-term follow-up?
There are a couple of main issues. First, there's the concern over cumulative radiation exposure, especially in young patients who will need monitoring for decades. You don't want to do repeated P scans unnecessarily.
Makes sense.
Second, and perhaps more importantly for management, is its relatively poor sensitivity in detecting low-grade or sort of smoldering disease activity. The inflammation really needs to be quite intense metabolically to produce a strong, unambiguous signal on PT.
So low-level silent damage could still be happening even if the scan looks negative or equivocal.
Exactly. Which is a major challenge in knowing when it's truly safe to reduce immunosuppression.
Okay. And finally, in diagnostics, we discussed those geographical differences in where the lesions tend to occur. How do clinicians and researchers standardize the reporting of these lesion locations globally so everyone's speaking the same language?
They primarily rely on the pneumonoangiographic classification system. It's sometimes called the Takayasu Conference Classification.
Pneumano system.
Yes. This system categorizes the disease into 6 main types, designated Type I through Type V, based purely on the topography, which segments of the aorta and its major branches are affected. There are also modifiers like C+ if coronary arteries are involved, and P+ if pulmonary arteries are involved.
It's purely anatomical.
Purely anatomical. Type I is just the arch branches. Type II affects the ascending aorta and arch branches. Type I includes the descending thoracic aorta too. Type 3 involves thoracic and abdominal aorta. Type 4 is mainly abdominal aorta and renals. And Type V is the most extensive, affecting the entire aorta plus branches.
Got it.
This standardization has been absolutely crucial. It allows researchers to accurately compare findings across different ethnic and geographical cohorts, confirming patterns like, for example, those high rates of extensive Type V disease seen in patients from South Asia and Mexico.
All right, we've established diagnosis is hard, the pathology is destructive. Now, treatment. The source material outlines a clear 5-armed approach to management. which really underscores the complexity of treating a chronic, relapsing, vessel-destroying disease like this.
That's right. The overall management philosophy really hinges on coordinating 5 vital arms simultaneously. You need early diagnosis, effective immunosuppressive therapy to halt the progression, timely invasive therapy for critical damage, ongoing vascular damage assessment, and absolutely the necessity of lifelong surveillance.
5 pillars. Let's start with medical therapy. You called it the cornerstone. We know, historically, glucocorticoids, or steroids, were the standard, but that's changed significantly due to severe side effects.
It really has. Using GCs alone, while they can induce remission, was just too problematic long term. They cause Cushingoid features, significant weight gain, osteoporosis, worsened diabetes, and blood pressure, basically increasing cardiovascular risk, which is the last thing a TAC patient needs.
Right.
And while high-dose GCs might induce remission in maybe up to 60% of patients initially, the relapse rate when trying to taper the dose down was simply unacceptably high. People would flare right back up.
So what's the current paradigm?
The consensus now represents a major shift. The most effective strategy involves combining lower initial and cumulative GC doses with non-steroid immunosuppressants, specifically disease-modifying antihemolytic drugs, or DMARDs.
DMARDs. So they are now the essential partners to minimize that steroid dependence and improve outcomes.
Mhm.
Can you explain the hierarchy here? There are conventional DMARDs versus the newer biologic ones.
Yes, and the European League Against Rheumatism, EULAR guidelines provide a pretty clear stepwise roadmap for this. Phase I, the initial induction phase to get the inflammation under control, relies on conventional synthetic DMARD CSDMARDs,
Like
methotrexate, azathioprine, or leflunomide. These are typically used alongside the initial course of steroids, allowing the steroid dose to be tapered more quickly and to a lower maintenance level. These agents work more broadly to suppress the systemic inflammation.
Okay, that's phase one. What about the more targeted biologic DMARDs? When do they come in?
Biologic DMARDs, or BDMARDs, represent phase 2 of the ELR strategy. These are drugs like tocilizumab, which very specifically targets the receptor for IL-6, that key pro-inflammatory cytokine we identified in the pathogenesis.
Right, the IL-6 connection.
Exactly. Or TNF-alpha inhibitors, which block another major inflammatory pathway. These biologics are generally reserved for cases that are refractory, meaning the disease is still active despite treatment with CSD-MARDs and steroids, or if the patient experiences a major relapse while on conventional therapy.
Okay. Now, the source provides a really interesting comparison between conventional and biologic DMARDs here,
Yeah.
highlighting a bit of a paradox.
Yes, Table 8 in the source lays this out. It suggests biologics are significantly more effective at inducing remission initially, maybe 84% remission rates with biologics compared to 64% with CSD-MARDs. And they also seem better at stabilizing the actual angiographic disease progression, stopping the lesions from getting worse on imaging.
That sounds clearly better. So what's the paradox?
The paradox is that, despite these higher initial remission rates, long-term use of biologics seems to be associated with higher rates of subsequent relapses compared to CSD-MARDs, and also potentially higher rates of adverse events and serious infections.
Wait, higher remission but also higher relapse. How do we rationalize that? That seems counterintuitive.
It is the critical paradox, and it's not fully understood. One theory is that biologics, particularly the very potent ones like the IL-6 blocker tocilizumab, are incredibly effective at suppressing the acute symptomatic flare and rapidly bringing down those inflammatory markers like CRP. They shut down the cytokine storm very efficiently.
Putting out the fire quickly.
Exactly. Highly effective fire extinguishers. However, the high relapse rate upon withdrawal or overtime suggests that while they control the acute inflammation, the symptoms and markers, they may not be truly resetting the underlying immune dysregulation. They might not be effectively eliminating the memory T cells or fixing the fundamental B-cell autoimmunity that continues to drive the disease long term.
So they manage the surface storm, but maybe not the deep currents.
That could be one way to think about it. They might be excellent suppressors, but perhaps not true remission inducers in the sense of curing the underlying process. This trade-off means doctors have to use them judiciously, often in combination or rotation with CSD-MARDs, and monitor very closely for relapse when trying to taper.
Fascinating. Now, we also noted earlier the surprising role of some non-immunosuppressive agents, like statins. Why are statins being recommended in TAC if their primary job is lowering cholesterol?
This comes down to their so-called pleiotropic effects benefits that go beyond their main mechanism of action. Statins possess known powerful anti-inflammatory properties. They can help stabilize atherosclerotic plaques, yes, but they also seem to improve endothelial function and reduce inflammation directly within the vessel wall.
Ah, so an anti-inflammatory effect separate from cholesterol.
Correct. And studies in TAC patients have actually shown that using statins is associated with a reduced rate of disease relapse, and this benefit seems to be independent of any actual cholesterol reduction achieved.
That's really significant.
It makes them a crucial, generally safe, non-immunosuppressive component of the overall therapy. Often, they're combined with antiplatelet therapy, like low-dose aspirin, which is vital for preventing ischemic events like strokes or TIAs, especially in patients who already have stenotic lesions in critical arteries like the carotids.
Okay, so we have steroids, CSDRNs, biologics, statins, antiplatelets, a complex cocktail.
Yeah.
But the ultimate challenge, as the source stresses repeatedly, remains assessing disease activity accurately. Clinical symptoms and those simple inflammatory markers, ESR and CRP, can be really misleading.
They absolutely can be. We see this all the time. The body is often compensating for slowly worsening blockages, and low-grade, simmering inflammation can persist silently within the vessel wall, leading to irreversible structural damage without causing overt fever or significantly raising the ESR or CRP. This is the core activity assessment dilemma.
So how do clinicians try to overcome this? How do they define active disease reliably?
They rely on structured criteria, most commonly the NIH criteria, developed at the National Institutes of Health. These criteria aim to provide a more objective definition of active disease.
Okay, what makes the NIH criteria so critical for actually tailoring the immunosuppression, for deciding whether to increase or decrease treatment?
Their strength lies in mandating the presence of two or more specific features to define active disease, and these must include objective signs, not just symptoms or nonspecific markers alone.
So what counts?
It includes systemic features like fever or malaise, or an elevated ESR, or, and this is key, new features suggesting vascular ischemia or inflammation, like a newly developed bruit, new onset claudication or diminished pulse, or definitive new angiographic changes detected on imaging like CTA or MRA showing a lesion has progressed.
Ah, so the imaging finding is crucial.
It's absolutely critical. The Kerr criteria explicitly include angiographic changes as a criterion. If imaging shows a lesion has clearly worsened compared to the last scan, the disease is considered active regardless of whether the patient feels perfectly fine or their blood tests look normal.
That prevents clinicians from being falsely reassured and easing off the therapy too soon, potentially allowing silent damage to occur.
Precisely. You have to actively look for new damage on the vessel wall itself.
Okay, now let's pivot to intervention. When medical therapy isn't enough or complications arise, we're talking open surgery or endovascular therapy, ET, like stenting. The source emphasizes that timing is absolutely everything here, and the risks are very high if that timing is wrong.
Timing is paramount, and intervening at the wrong time carries a huge risk. Invasive therapy, whether it's a surgical bypass graft or an endovascular procedure like angioplasty or stenting, is strictly reserved for life or organ-threatening situations.
That's it.
Things like severe, uncontrolled hypertension due to renal artery stenosis, critical limb or organ ischemia causing severe symptoms or dysfunction, progressive heart failure due to valve issues or aortic problems, or rapidly expanding aneurysms at risk of rupture.
So high-stakes scenarios.
Very high stakes. And crucially, these procedures absolutely must be avoided, if at all possible, during periods of active disease. Intervention should ideally only happen when the inflammation is well controlled, when the patient is in remission.
Why is intervening during active disease so risky? What actually happens inside that inflamed artery?
When the artery wall is actively inflamed, full of those immune cells, cytokines, growth factors, it's in a hyperreactive and hyperproliferative state. If you then go in and perform an angioplasty, which stretches the wall, or place a stent, which is a foreign body...
The inflamed artery sees it as another injury.
Exactly. The ongoing inflammatory cascade often treats the intervention itself as a further insult. This triggers an aggressive, almost pathological healing response that frequently leads to rapid restenosis. The vessel just scars down and re-narrows very quickly, sometimes worse than before.
So the fix doesn't last.
Often not. And in the case of open surgery performed during active inflammation, there's a much higher risk of serious complications like suture lines failing, graft infections, or the formation of anastomotic aneurysms, dangerous outpouchings where the graft connects to the native artery. There's even data suggesting increased mortality if surgery is done during active TAC.
That really explains the extremely guarded approach. Now, when comparing the two main options for obstructive lesions, surgical bypass versus endovascular therapy, the data on restenosis rates is pretty eye-opening.
It is perhaps the single most defining data point when choosing between the modalities for blockages, assuming the patient is in remission. Restenosis, or reblockage, is a major problem after endovascular therapy, ET, for TAC lesions. Reported recurrence rates are often cited as being around 43%, sometimes even higher in certain series.
Nearly half the time it fails long term.
It's a significant failure rate. In contrast, open surgical bypass grafts, while obviously a much more invasive procedure initially, demonstrate significantly better long-term durability. A large meta-analysis cited in the source suggests the occlusion rate for surgical bypass grafts in TAC is much lower, maybe around 17%.
Still not zero, but much better than ET.
Much better. So for the patient, this often means surgery, while a bigger upfront operation may offer better long-term freedom from reintervention. Endovascular stenting is minimally invasive, which is appealing, but carries that much higher risk of needing repeat procedures down the line.
Does this difference in durability specifically dictate treatment choices for certain vital organs, like the heart?
Yes, it definitely influences practice patterns. For coronary artery involvement, which occurs in roughly 18% of TAC patients and can cause angina or heart attacks,
Right.
coronary artery bypass grafting, CABG surgery, is generally the preferred revascularization strategy precisely because percutaneous coronary intervention, PCI, or stenting, in TAC patients is associated with such a significantly higher restenosis rate compared to non-TAC patients. The stents just don't hold up as well in these inflamed vessels.
So bypass is usually favored for the heart. What about aortic aneurysms?
For aortic aneurysms, open surgical repair remains the gold standard, especially for complex aneurysms involving major branch arteries. However, endovascular aneurysm repair, EVAR, using stent grafts is becoming more common, particularly for less complex anatomy. But again, the absolute prerequisite is that the underlying inflammation must be tightly controlled before attempting either open or endovascular repair to minimize the risk of graft complications.
Okay, moving into some special considerations. Given that this disease predominantly affects young women, often in their prime reproductive years, pregnancy must be a major area of concern and careful management. What does the source material say about the risks and the advice specialists need to give?
Yes, pregnancy in women with TAC requires very careful planning and multidisciplinary management. The disease itself significantly increases the risk for adverse outcomes for both the mother and the baby. Studies show quite high rates of complications, maybe around 40% obstetric complications and 39% maternal complications overall.
What's the main maternal issue?
The primary maternal complication is hypertension, either new onset high blood pressure during pregnancy or worsening of pre-existing hypertension, which can lead to preeclampsia. Active disease at the time of conception is a strong independent risk factor for poor outcomes for both mother and fetus.
So conception really needs to be planned very carefully. It can't be accidental.
Absolutely not. The universal guidance is that conception should only be planned, ideally, after the patient has achieved a sustained period of remission, meaning the disease is well controlled on stable medications.
And medication management is key.
Crucial. Before conception, specialists must review all medications and switch the patient to drugs considered relatively safe during pregnancy. Things like methotrexate or leflunomide are teratogenic and must be stopped well in advance.
What's generally considered safe?
Labetalol is often the preferred drug for blood pressure control. For immunosuppression, azathioprine and low to moderate dose steroids are generally considered compatible with pregnancy, though close monitoring is still needed.
And what about delivery?
While vaginal delivery is often possible and preferred if the mother's condition is stable, a cesarean section may be necessary or recommended if the mother has severe refractory hypertension, significant aortic regurgitation putting strain on the heart, or certain types of critical aortic lesions. It requires careful team planning involving rheumatology, cardiology, obstetrics, and anesthesia.
Okay, now let's return briefly to the eye, where this whole story began with Dr. Takayasu. If ocular involvement occurs, what does it typically signify about the disease pattern?
The common ocular manifestations are things like Takayasu retinopathy, those characteristic vascular changes in the retina or more severe ocular ischemic syndrome, and also hypertensive retinopathy if blood pressure is very high.
Right.
The really key clinical finding here, correlating back to the original discovery, is that Takayasu retinopathy and ocular ischemic syndrome are almost exclusively associated with significant involvement of the aortic arch and its branches, the vessels supplying the head and neck. And typically, these patients have very low or even non-recordable blood pressures in their upper limbs because of the blockages.
So it confirms that 1905 hypothesis, The eye findings really are a direct proxy for critical upstream arterial obstruction in the neck and chest.
Precisely. It validates that initial connection made over a century ago.
And is there effective intervention if vision loss starts to occur due to this ocular ischemia? Can anything be done?
Yes, there is potential for intervention. If the carotid artery stenosis is identified as the cause of the ocular ischemia, then carotid revascularization, either through open surgery, carotid endarterectomy, or endovascular stenting, has been shown to be effective in improving both acute vision loss and sometimes even chronic visual symptoms.
So restoring flow can save sight.
It can, although naturally, the prognosis for vision recovery is always better if the intervention happens before severe, irreversible retinal damage or optic nerve atrophy has occurred. Early detection is key.
Okay, looking now at the overall prognosis. Despite all the complexity, the destructive nature we've discussed, has the outlook for patients with TAC actually improved over the last few decades?
Oh, it has improved dramatically, really monumentally. This is largely thanks to earlier diagnosis, more structured assessment of disease activity, and especially the advent of strategic combination medical therapy using DMARDs and biologics alongside steroids.
So what are the survival rates like now?
Survival rates are now generally considered excellent for TAC, especially compared to historical cohorts. Recent large studies report overall survival rates often exceeding 95%, maybe 97% at 10 years, and still quite high, maybe 86% or so, at 15 years post-diagnosis.
That's a huge shift from what it must have been before effective immunosuppression.
A massive shift. Previously, mortality was much higher due to uncontrolled vascular complications like stroke or aneurysm rupture.
But certain features, presumably, still carry a negative weight. What are the key negative prognostic indicators that tell clinicians this patient needs the most aggressive monitoring and treatment?
Yes, despite the overall good prognosis, certain factors are known to predict a worse outcome. These include having a progressive clinical course, sometimes called a crescendo pattern, where the disease rapidly and repeatedly worsens despite treatment. Also, the development of major vascular complications early on, like stroke, heart failure, or significant aneurysms. Involvement of the thoracic aorta, particularly aneurysms there, carries a higher risk due to potential rupture. And finally, the presence of significant retinopathy is also considered a marker of more severe, extensive disease and poorer long-term prognosis. These patients require the most vigilant surveillance.
All right, so finally looking forward, what does the source suggest are the critical remaining research gaps? Where does the field need to go to push survival and quality of life even higher for these patients?
The roadmap for future research is really defined by the current limitations we've touched upon. First and foremost, we desperately need robust, universally accepted, gold standard criteria that can definitively diagnose TAC early and reliably measure active disease versus damage consistently across different centers worldwide.
Better diagnostic and activity tools.
Exactly. Second, we urgently need reliable biomarkers. Ideally, a simple blood test or maybe a panel of tests that could not only help diagnose but also predict disease course, predict which patients will respond best to which specific biologic or DMARD.
Personalized medicine for TAC.
Precisely. And track disease activity more accurately than ESR or CRP. Third, we need safer yet highly sensitive imaging techniques. Methods that perhaps reduce or eliminate radiation exposure compared to repeated CTs or PTs, but can still reliably detect that low-grade smoldering vascular inflammation that PET often misses.
Safer, smarter imaging.
Yes. And fourth, fundamentally, we must continue basic science research into the pathogenesis, the why and how to uncover novel molecular targets. This could lead to the development of entirely new classes of drugs that might offer true remission or even a cure rather than just suppression.
And anything else on a larger scale.
And perhaps most practically, the source highlights the critical need for a truly global patient registry, one that captures the full spectrum and heterogeneity of TAC across diverse ethnicities and geographical regions worldwide.
Why is that so important?
Because without standardized, large-scale global data, our ability to make meaningful comparisons across different ethnic groups where we know the disease behaves differently in terms of presentation and location will always be hampered by small sample sizes and inherent biases in single-center or single-country studies. We need the big picture. #outro.
What an incredible deep dive. It really paints a picture of a profoundly challenging but thankfully increasingly manageable disease. Takayasu Arteritis. Rare, tough to diagnose early, but with outcomes that are vastly improved now, thanks mainly to that strategic combination immunosuppressive therapy and the very careful, timed use of invasive procedures when absolutely necessary.
I think the critical takeaway, especially for clinicians or trainees listening, has to be the absolute necessity of lifelong surveillance. This is fundamentally a chronic relapsing disease. Even after a patient achieves clinical remission, even if their symptoms are gone and their lab markers normalize,
The vigilance can't stop.
it cannot stop. The patient must be continuously monitored, often with periodic imaging, indefinitely. We're looking for silent progression of vascular damage, for subclinical relapses. For TAC patients, the fight unfortunately never truly ends. It just changes focus over time, shifting from controlling active inflammation to managing the long-term consequences of scarring, obstruction, and potential aneurysms. It requires a lifetime commitment from both the patient and the medical team.
And maybe a final thought for you, the listener, to reflect on. Consider those very earliest, often missed warnings, that vague constitutional stuff like unexplained fever, malaise, significant weight loss. How many of these potentially catastrophic vascular outcomes, the strokes, the heart failure, might be averted if those seemingly benign signs were flagged earlier, investigated more thoroughly, especially in that key demographic of young women, perhaps those with a known genetic predisposition like HLA-B52. That fundamental shift in clinical suspicion at the primary care level, recognizing these nonspecific symptoms, could be the whisper of impending vascular disaster. That remains the ultimate challenge, and perhaps the greatest opportunity for improving outcomes even further worldwide. Thank you for watching The Funnel Effect.